Okay, so we keep going with our microbial parade, and the next genus on the list is Mycobacterium. You may feel a little confused here, thinking, come on, it's not gram-positive, it's acid-fast. Well, if you would think about the structure of the cell wall, it looks like gram-positive. Because Mycobacteria, if you would look at the cell wall, have a layer of the membrane, then they have the cell wall, which is pretty thick, and then they have mycolic acid. So with the exception of mycolic acid, what's left is gram-positive cell wall. Okay? Now, there are three major species that we're going to talk about. It's Mycobacterium tuberculosis, Mycobacterium avium, and Mycobacterium leprae. Now, practically for all of them, okay, the virulence factors is going to be two things. It's a capsule and intracellular replication. And I want to open up on that. By intracellular replication, so it doesn't only replicate either Mycobacterium avium or Mycobacterium leprae. They not only replicate inside of the cell, they replicate inside of the very specific cell. And this specific cell is the macrophage. So this is something that I can ask you. So Mycobacteria replicate inside of the macrophage. What is the function of a macrophage? Phagocytosis. It's a part of the immune system. So there is no better place to hide, right, from immune system than inside of the immune system. It doesn't see itself. So these microbes can be stained with acid-fast stain. You can see here the red cells are acid-fast. Okay. Now, without any separation yet between, in terms of symptoms, between the Mycobacterium avium or tuberculosis or leprae, let's think what's going on. Mycobacterium infects macrophage and replicates in it. And it turns out to be sort of an arms race, a battle that cannot be won by either of the parties. For immune system, it's much harder to destroy an infected macrophage, especially because it is hard to recognize that it is infected. Okay? Replication of Mycobacteria inside of the macrophage, though, will trigger the local immune response. So you're going to have infected macrophage, more than one, okay, that will be all located next to each other. They will skew immune response. There will be immune infiltration, T cells, for instance. So there will be constant smoldering inflammation in a certain part of the tissue. So far, does that make sense? That is really hard to eliminate. T cells won't be able to eliminate it. They cannot kill macrophage. Macrophages cannot eliminate because they are infected. So you have smoldering inflammation. How can you, I don't want to say get rid of it, you can't. But how can you stop it? I will have to quote the current president of the United States. What is the solution for the immigration problem? Build the wall, right? Your body does the same. It cannot do anything else but to build the wall around the inflammatory focus. It essentially forms a fibrin encasement around the that inflammatory place. Does that make sense? So in the center of that lesion, the center of that granuloma is necrotic. And microbes, a unique feature of mycobacteria is that they can pretty much stop replicating without dying. So they go dormant. And the person may actually have mycobacterial granuloma inside the body for years and years and years and go absolutely asymptomatic. The person may not shed microbes, may not produce microbes. There will be no transmission involved. Does that make sense? Sort of a quiet tuberculosis, non-infectious form. Does that make sense? The microbe is hiding. It's not in the saliva, it's not in the sputum, it's not in the respiratory secretions. This person is not infectious to other people. That makes sense. However, in case of immunosuppression, this granulomas, they change completely because immune system stops suppressing them and microbes start to replicate more actively. They respond to changing immunological environment. They start to replicate and person develops active, clinically noticeable tuberculosis. So if immune system is suppressed, tuberculosis may become active. Yes?
So if somebody has tuberculosis and then they receive treatment with those drugs,
Mm-hmm.
it's still there, but it's like...
Can you clear the person from tuberculosis? Yes, you can. You have to treat the active fulminant tuberculosis, though. Does that make sense? Sure. When microbe is hidden in the granuloma and there is very little replication, drugs cannot target anything because drugs act on the cellular processes that happen in the dividing cells. When cells do not divide, the person has latent tuberculosis infection, then drugs will be largely ineffective. If the person has a fulminant tuberculosis infection, meaning that it replicates and reproduces and the person is infectious, then treatment will be effective. Does that make sense? It will target replicating cells. It will kill replicating cells. And yes, you can treat the patient so that tuberculosis is not detectable anymore. But you will always test positive for tuberculosis, meaning you were exposed. Your T cells were exposed to tuberculosis and will be always positive. So, brief answer, can you completely get rid of the Mycobacteria tuberculosis? The answer is yes, you can.
How would you know if it's gone all the way, though, if you always test positive?
Probably there's no way, but granulomas can be seen on the X-ray, for instance, or in the MRI. So you can see denser areas in the tissue. Does that make sense? Let's get this out of the way. The Mycobacterium leprae. Okay, so this is pretty much this is the infection of tissues. Leprosy. Okay, there are two forms of leprosy. The lepromatous form, which is this, and granulomatous form. So granulomatous form is the formation of granulomas in different tissues. This is the sort of a classical illustration. It is called a lion's head. I don't know why. But that facial appearance is the lion's head. Tissues are not getting destroyed. So granulomatous form is milder. Lepromatous form is when Mycobacterium destroys the tissues. The thing is that during leprosy, nerve endings are destroyed as well. So people do not feel the destruction. it usually goes with limbs. It's toes and fingers. Okay, so people may say lose the finger, quite literally lose the finger without feeling it. Okay. It is very easily treated now. There's a drug called Dapsone. It's one of the sulfa drugs, and you know, it's not really dangerous. It's common still in India and in Asia. In the United States, what was the hotbed of leprosy in the beginning of 20th century? Does anyone know? Arguably the most beautiful state in the United States. A vacation spot. But it's really expensive to go there because of Hawaii, yes. It was a huge hotbed for leprosy. It's zoonotic disease, so armadillos are reservoir, but people can transmit leprosy by contact, person to person. And the island of Molokai, it's one of the Hawaiian islands, was used to accommodate people with leprosy. Don't get me wrong, it wasn't a hospital. It was a prison. So people with leprosy were forcefully moved to Molokai to prevent the spread of disease in the general population. And as far as I know, they were not allowed to leave the island and stay there till they died, which was pretty horrible fate because at that point it was practically rotting alive. I don't know if I think there were some compensations from the government for the victims and the relatives of victims who were forcefully moved there. But from epidemiology, like if we leave ethics behind, from epidemiology standpoint, it makes perfect sense. Because if you can remove all people or timely remove people with leprosy from the population, you can curb the spread of disease. Because people usually don't hug armadillos. It's really hard to catch one. Now, tuberculosis. It is really contagious, okay, but it is not doesn't cause the disease in every case of infection, right? So only about 5% of people who are infected become really sick. It is a characteristic disease for the places where sanitation is poor and where people are crowded. And we discussed India and its contribution to drug-resistant infections before. India is extremely crowded place. There are a lot of people there. Okay, like really a lot of people there. Another crowded place is the Russian prison. It is, I can't even explain how hugely it is overcrowded. People sometimes, so there are so many people in the cell that they have to sleep sitting, not lying down, because there's not enough space. So they have to take shifts sleeping. So in this place, and as you can imagine, sanitation is far from perfect. I just by reading Russian news and speaking with people, I know that if you go into the prison back home, it practically guarantees you tuberculosis. It's like for free. From penitentiary system, it's a gift, free gift. Now, my father-in-law he used to work as a contractor. He worked with the special hospital for people with tuberculosis. Because you don't want to put a bunch of people with tuberculosis in like a general infectious disease block. So there was a special building, and he did some like renovation stuff for them. So I once helped him out with some work, and we were there, and you can just tell, you look at the patients, and you can tell probably 90% of them spend some time in prison. Okay. So it's pretty common there. So you can detect tuberculosis by tuberculin reaction. It's a hypersensitivity type 4, intradermal injection of tuberculin, which triggers the bump. Unfortunately, it does not differentiate between the vaccination, and I was vaccinated against tuberculosis when I was a kid, and actual disease. Major component of tuberculosis pathology is the host response, host immune response, infiltration by cytotoxic cells and macrophages. On the X-ray, the lobar infection tuberculosis manifests as, you can see like a white inflammatory area in the lung, and when those when macrophages infected with Mycobacterium, they assemble together, they form that necrotic center of the granuloma, okay, which sometimes you can see characteristic giant cells and granuloma cells. But the point is that upon the initial infection, which can be very mild, coughing, okay, Mycobacterium goes away, stays dormant in those macrophages. However, if the infection reactivates due to the impaired immunity, okay, then and bacteria ends up in the upper respiratory tract, it causes chronic cough, green sputum, blood in the sputum, night sweats, fatigue. If you would read the accounts, many American writers dedicated their novels and parts of the novels and short stories to victims of tuberculosis, which was extremely common in the United States in the beginning, first half of 20th century. It was very, very common. There was no treatment. People moved to Arizona hoping to recover from TB. I think it was more of a easier to breathe compared to the muggy and humid air of New York, for instance, and there were also less people, better conditions, let's put it this way, but people didn't really recover. It's practically impossible. Now, when mycobacteria, you can see them here, this little tiny red ones, when mycobacteria spill from lungs into the systemic circulation, that is called extrapulmonary or miliary tuberculosis. Okay, and when it goes into the other organs, the prognosis is honestly very poor. Tuberculosis is hard to treat. There are very few effective drugs, rifampin and isoniazid. Okay, you can treat with tetracyclines, of course, and aminoglycosides, but we will discuss why they are largely ineffective. So it can cause osteomyelitis, it can cause kidney infection, it can cause meningitis, it can cause myocarditis and pericarditis, different types of heart infections. Prognosis is poor. My great uncle died at the age of 38, I think, 35, because of the bone tuberculosis. And what kind of triggers extrapulmonary tuberculosis? If you would look at the countries where tuberculosis is most common, okay, Africa, some Asian countries, they poor, more or less, which means poor healthcare, poor sanitation. People do not have regular access to the financially available drugs. So if you have two doctors, and one prescribes the proper course and another tells you, in a week you're going to be fine, you're going to pick the one with in a week you're going to be fine because it's going to be cheaper. Okay, so that all goes in the way improper treatment, more resistance, less effective drugs. Does that make sense? That's quite an important thing. Now, don't get me wrong. Now, I'm kind of protective of my country. Russia is huge, and there are many tuberculosis cases. But don't think that, you know, like walk down the street and people just coughing blood. No, okay. They localized its prison populations, and people who, you know, get out of prison, they often don't have money to move to large cities, so it would be like smaller cities located closer to the prisons and whatnot. Does that make sense? So it's mostly more of a hotbeds of tuberculosis. Another disease that goes hand in hand with tuberculosis, or vice versa, whatever you prefer, is AIDS. So AIDS means that the person is immunosuppressed, which means that if tuberculosis used to be latent in the person with AIDS, it becomes fulminant, it becomes acute. Does that make sense? So if you would look at, if you would try to find information about tuberculosis treatment, especially in Africa, you will see that in many cases, the charity organizations distribute both anti-TB and anti-HIV treatments. Because treating one without treating another doesn't really make sense due to the reinfections and so on and so forth. Vaccine is not really effective. So I have BCG vaccine named after two French dudes. Of course I cannot remember them. I never remember the names. Its efficiency is pretty low. Estimates are different, about 70% probably. The main point, and you can say, well, if it's so ineffective, why do we give it to people? It is given at the age of 3 days, and the purpose of that vaccine is to build up immune response sufficient enough to prevent infection of a child. Does that make sense? So it increases protection of kids in the countries where there is a transmission. In the United States, tuberculosis transmission is not really a factor. Does that make sense? We don't have a lot of people with TB. Does that make sense? So understand the transmission for tuberculosis, and we discussed the drug resistance. Major cause of drug-resistant tuberculosis is what? Why TB becomes drug-resistant? Improperly. Use it improperly. We think, oh, this dude's fine, let's just stop treating. It's a long-term course, up to 4 months of antibiotics, and if people are non-compliant. Okay, understand the difference between extrapulmonary and pulmonary tuberculosis. Okay. Transmission, virulence factors, those two that I told you. Replication in macrophages and capsule. Mycobacterium avium is kind of boring. It's tuberculosis. Pretty much it works just like tuberculosis, but it affects exclusively immunocompromised people. So if you're healthy, you're not going to get it. If you're immunocompromised, you have a good chance. NOCARDIA and CORYNEBACTERIUM. Now, these microbes are grouped in kind of an awkward way. I try to save space so you don't have to print abominable number of slides. So NOCARDIA is a pretty mild nosocomial infection that affects severely immunocompromised patients. I'm not going to ask you about any virulence factors regarding nocardia. Don't worry about that. Nocardia steroides causes pneumonia. It's very, very frequent cause of nosocomial disease. That's what I want you to remember about nocardia. It's a nosocomial opportunistic pathogen. Okay, it's also an acid-fast bacteria, so it's weakly acid-fast bacteria. So essentially, in a healthy people, you can see the yellow nocardia colonies here in that illustration. In healthy people, in immunocompetent people, nocardia doesn't pose a serious risk to the health. Unlike CORYNEBACTERIUM, diphtheria. Don't expect me to ask you the question, which disease CORYNEBACTERIUM diphtheria causes. I don't like to ask questions which contain the answer. Okay, so no. And the virulence factor that I ask you to know is, the toxin. The exotoxin that inhibits translation. The component or subunit A of the toxin binds to the translation factor EF2, inhibiting the translation essentially. When cells cannot make proteins, they die. CORYNEBACTERIUM diphtheria is the respiratory pathogen, and the main route of transmission is, of course, respiratory. It infects epithelial cells of upper respiratory tract, causing them to die. Death of epithelial cells leads to the local inflammation, and inflammation attracts which immune cells, first and foremost? Innate immune cells. What do you do with the dead or inflamed cells and bacteria in the site of infection? What your innate immunity does with them? Phagocytose. So you have to they attract phagocytes, neutrophils and macrophages. Neutrophils die, macrophages not really, but eventually they will. So all these dead bacteria, dead neutrophils, dead epithelial cells form a structure called pseudomembrane. Okay, so the membrane, when it grows large enough, can block respiratory passages, leading to the suffocation. But even without suffocation, CORYNEBACTERIUM diphtheria infection is severe. Very high fever. It quite easily goes systemic and can cause endocarditis, infection of the cardiac valves. Okay? Does that make sense? We have very effective vaccine, the component of DTaP vaccine. And to prove that it is effective, I can tell you, in 1991, Soviet Union collapsed. And all government institutions, I wouldn't say they collapsed as well. It wasn't like a chaos, nothing like a bear cavalry, on the streets and looting and robbing. No. But functionality of the government institutions kind of sort of decreased. And such thing as vaccination, which used to be mandatory, people started to just telling doctors, I'm not going to do that. That was Russian version of anti-vaxxers. And doctors, of course, they couldn't care less. Said, okay, whatever. I'm not gonna pursue you. There's nobody I can report you to. If you don't want to vaccinate your kids, no problem. I don't care. Well, guess what? The sweeping epidemic of diphtheria. Several hundred people died of diphtheria. And it's bacterial disease. You can treat it with antibiotics, You can treat it. Okay? Several hundred people died. And after that, and I remember that, we had people coming to schools. Not just random people, doctors, nurses coming to schools with a giant needle. Well, I was not so big of a child, so for me all needles were giant. And they vaccinated everybody indiscriminately. okay, just to prevent the spread. And at the time, for some reason, the vaccination wasn't in the deltoid muscle. They did it in the infraspinatus, which pretty much means in the shoulder blade. God, that was painful. Not in the bone, but just sticking the needle in there, that was painful. This is awful, awful injection. So, transmission, virulence factor, cytotoxin, disease. Remember that it forms pseudomembrane, and that we have a vaccine. Actinomyces and Gardnerella are two examples of generally benign bacteria. Actinomyces, for instance, is the common soil bacteria, okay? Also, actinomyces can be found in the oral cavity of a human. By the way, human bite is considered to be the worst among all other animals in terms of the microbes that can be transferred into the wound. I mean, I'm not talking about rabies. We're not touching on that, but if you compare human bite with a healthy dog bite, human's going to be worse. So actinomyces can cause the subcutaneous infection that is called a lumpy jaw. And if it goes systemic again in the immunosuppressed patients, it can cause all kinds of diseases starting from pulmonary infection, essentially pneumonia, to gingivitis and diverticulitis. Okay? It is not common to have in the healthy people. Gardnerella vaginalis is, you can see it here, the Gardnerella cells. I specifically say here that it's associated with vaginosis because it is still not completely settled if Gardnerella is the causative agent of vaginosis, or it is associated with, how should I say it, with disturbances in the vaginal flora and serves as the sort of predictor for the future disease. Does that make sense? Do you understand what I mean? So if the flora has been altered by, let's say, antibiotic treatment, Gardnerella will have more options to grow, and that alteration will almost inevitably lead to, I don't know, candidiasis or some other type of infection, okay? And it's still not settled whether Gardnerella by itself can cause vaginal inflammation or it is just associated with the vaginal inflammation in the future. Does that make sense? Okay. So, no virulence factors for these two guys. Okay, don't worry about that. Just then you know, Gardnerella is associated with the vaginal discomfort, actinomyces, mostly the subcutaneous, the lumpy jaw infection, and pneumonia. Now, enterococci, Propionibacterium MYCOCOCCus, enterococci, Enterococcus fecalium and Enterococcus faecium, which I don't list here, enterococci are a normal component of human microbiome in the gut. They're present there, okay? However, when they leave the intestines, they may end up in the most uncommon places, causing diseases like urinary tract infection. That makes sense. Meningitis. But usually meningitis goes after the sepsis or after the bacteremia. So often Enterococcus fecalis enters the organism either via the urinary tract or via the wound, becomes bacteremic, gets to the heart, where it causes endocarditis, and if it reaches the brain, it can cause meningitis. You can see the diplococcus dividing enterococcus here. Okay? Can be fairly effectively treated, but unfortunately, the vancomycin-resistant strains of enterococcus become more and more abundant. And look at this. If you have a microbe that is present in your gut, by you I mean not personally you, but you as the people, humanity, okay? We treat people with antibiotics. So those gut microbes are constantly exposed to antibiotics. Does that make sense? So in order to survive that treatment, they develop resistance. And they may not cause any disease when they're in the gut. But once they get in the wrong place, brain or heart, which is sterile, they, first of all, they will cause the disease. Second, it will be awfully hard to treat because of the resistance. Does that make sense? So I kind of show it here. It is resistant to a bunch of antibiotics. Okay. Propionibacterium acnes survives in the hair follicles, and it is normally present there. You can see those quite unremarkable bacilli here. So it uses the sebum, which is rich with fat, as the major source of nutrients. And when people go through the adolescence, the puberty, changes in the endocrine levels of hormones, they trigger overproduction of sebum. It's mostly testosterone in males and estrogen in females. So androgens increase the sebum production. Increased production of sebum allows Propionibacterium to flourish, okay, to reproduce in the large numbers. And if you think about this, any microbe that is a component of a microbiome, like Staph epidermidis or Propionibacterium acnes, is tolerated by the immune system. But it is tolerated to a certain level. Does that make sense? So it is not detected by immune system up to a certain level. When Propionibacterium acnes starts to reproduce in sufficient amounts, the white blood cells, your immune cells, will recognize it and will develop non-specific response, leading to inflammation, leading to acne. Okay? Now that can be treated by the topical antimicrobial cream. Sometimes, though, the systemic, the oral antibiotic are warranted in case of severe acne. And what is the main, well, except for cosmetic inconveniences, what is another possible problem associated with acne? Yeah, secondary infections, of course, because the integrity of the skin is impaired, and people can acquire secondary infection. And one of the most dangerous sites for this is face, for any secondary infection, because it's very close to the brain, and the time that it takes for the microbe to travel, to get, especially if it can get into the tissue and migrate through the tissue, it can actually skip the bacteremic part, get to meninges, for instance. Okay. Micrococcus luteus is those yellow colonies that you saw when you sampled your skin during the hand wash. We cannot consider it a primary pathogen. It's a typical opportunistic pathogen. Very rarely it causes the disease. Okay, it is associated with a disease in severely immunocompromised patients. It can cause wound infections, sepsis, pneumonia, endocarditis. Think about this. If you would look at practically all bacteria that we discussed, whether they are opportunistic pathogens like Mycococcus or primary pathogens like Corynebacterium, diphtheria, you will notice the same pattern. they either not causing the disease or cause pretty specific type, like Corynebacteria. However, if they get into the blood, the sites affected become common between them. Heart, brain, kidneys. Because those sites in the body are what? Sterile. There's no competition, so practically any microbe can colonize them, and it's not colonize, it can infect them and cause pathogenesis. Does that make sense? No virulence factors here, except for one thing, the antimicrobial resistance for Enterococcus. And please remember a discussion. It is constantly exposed to oral antibiotics that we take. It develops that resistance. Okay? Mycoplasma. We put it in the gram-positive. Now, the reason why is not because it is structurally gram-positive, but because it is stained as gram-positive microbe. If you will do the staining, it's going to be gram-positive. Okay. Two species that I want to mention. Mycoplasma pneumonia is often referred to as mollicute. As you can get from the name, it causes so-called walking pneumonia. And Mycoplasma doesn't have a cell wall at all. So it has sort of a variable shape. You can see these protrusions, that's Mycoplasma. You can see the stretched Mycoplasma cells on the picture B. Okay, can be treated. Pneumonia is usually, well, mild compared to others. Can be very effectively treated with azithromycin. Azithromycin is very, very effective against it. Okay. Respiratory transmission, of course, there's no vaccine. I'm not asking about any virulence factors associated with Mycoplasma. Now, Mycoplasma genitalium is the causative agent of urethral inflammation and inflammation of the uterine endometrium. Okay, so it's the sexually transmitted disease. Okay, and inflammation that starts in uterus can then migrate by fallopian tubes towards ovaries. When infection is in the fallopian tubes, which process starts in the fallopian tubes? Infection leads to well, we kind of try to figure out why it can lead to sterilization. When you have an infected site, it's going to look how? Inflamed. So there's going to be inflammation. Inflammation ultimately ends in repair. So inflamed tissue should be destroyed, right? And replaced with a healthy one. The healthy one is going to be connective tissue. Okay? So repair, quote unquote, repair of infected fallopian tubes may lead to the inability of secondary oocyte to pass through the fallopian tubes. So that's sterilization, right? Moreover, Mycoplasma gets all the way through the fallopian tubes and gets out of the ampulla of fallopian tubes into the peritoneal cavity. It can cause inflammation of peritoneum and all together. So now we have involvement of fallopian tubes, uterus, and peritoneum all together. This is called pelvic inflammatory disease. Very hard to treat, painful, and the problem with almost all urinary, not urinary, but sexually transmitted diseases is that they very often go unnoticed in both men and women, and by the time the signs and symptoms develop, the infection may progress too far and cause irreparable damage. Now we're going to talk about it tomorrow.